Again, this is an important topic. We have given lots of OSCEs in the recent past. We have given lots of MCQs, and there have been some essay questions. And in the clinical viva, in the long show, in the cases also, we have we have asked questions frequently. Okay, and also in the real life, in the when you go to practice, you will even as a GPs, you will come across, and when you are a house officer, you may need to counsel women how to do uh, how to induce ovulation. Okay, so ovulation is I'm not going to repeat this. You have learned this. There are three, two phases: follicular phase and luteal phase. And in the follicular phase, one follicle will be kind of a cohort of follicles will be recruited, and at some point one will become a leading follicles, and the rest of the follicles will only support the leading follicle will mature, and on 14th day the rupture of the follicle occurs, and that process is called ovulation on day 14th of the cycle, provided the cycle is a 28-day cycle. And then second, after that, if the fertilization does not take place, and then corpus luteum will begin to form, and this is a secretory phase, and this is called, again it is called luteal phase also. Okay, so actually very interesting thing is, in the follicular phase, a cohort of eggs, a few number of eggs will be recruited, and they begin to grow, and one will become dominant or leading follicle. So with this knowledge is important. So you need to uh, you know and one of these eggs will respond to respond to the FSH hormones, and that will produce, in return, that will produce that growing follicle, and cells will produce estrogen also. Then there will be a negative feedback mechanism will be set in, and slowly there around day 14 of the day, there will be a surge of LH and FSH. This LH surge will trigger the ovulation. Just this basics you should know. This you have learned this, studied it in physiology also. Hypothalamus will secrete GnRH, gonadotrophin releasing hormone, and that will have some influence on pituitary glands, and pituitary will produce FSH and LH, and FSH and LH will stimulate ovaries, and ovaries will produce estradiol and progesterone. This is the basic function of the hypothalamo-pituitary ovarian axis. Okay, so this knowledge is enough for you to work clinically. Okay, so when a subfertile couple comes, while doing the assessment of the male functions like sexual, taking the history and seminal fluid analysis, you should also take some details regarding the female partner to see whether they have ovulation. They ovulate. Ovulation, when there is a regular periods, when a woman complains of regular cycles, 95% of the women do ovulate regularly. When a woman when woman says I have regular cycles, that means 90%, 5% of the time she is ovulating. So history is very important. And normally in the clinical setting, what we do is we ask the woman to come on day 10, 11, or 12th day to check whether she has a leading follicle. Okay, so we ask them to come on day 10, day 11, day 12. Or else for your level, at your level, if you say day 12 scan, that is the That is to check whether she is going to ovulate, or this is to check. This is called follicular tracking. This mechanism is called follicular tracking. This is very important. When we do a follicular tracking, or when you do a day 12 scan, we not only look at the eggs, we also examine the uterus. We would like to know whether uterus is formed, well formed. Uterus become a triple layer endometrium. Uterus becomes normal size, but endometrium will become a triple layer endometrium when there is an dominant follicle. If that endometrium is thickened and triple layered only, there is a high chance of fertility when they meet a sperm. Otherwise, what will happen is, if it is a thin endometrium, that is not a receptive endometrium, and even if the ovulation, if the eggs come out, implantation won't occur. So in the clinical setting, what we do is, when we measure the day 12 follicle size, we also measure the endometrium. We also can measure the blood flow to the endometrium. We can grade it, and then we document it. If the endometrium is thin, there are medications to improve the quality of the endometrium. One is we give estrogen valnerate. We give Progynova we give it for 7 days. Sometimes we give aspirin. There is a kind of there are some studies that we can very well use magnesium supplements, and sometimes vaginal Viagra is also said to improve the quality of the endometrium. Vaginal Viagra, aspirin, magnesium supplements, and of course some lifestyle modifications. Okay, so you should know that it's not the size of the egg, it is the size of the leading follicle. And also sometimes, if not only one, if there are 4 or 5 follicles, then there is a chance of multiple pregnancy. So you have to warn that. So day 12 scan is important. In the day 12 scan, we can predict the ovulation. Okay, and there are features. Not only these are for the registrars. When there is a good follicle, we look at the size, we look at the shape, regularity, we look at the perifollicular fluid collection, all these things. Sometimes when you do a scan, you may not see an egg. Instead, you will see only a little bit of free fluid. That means she has ovulated. Okay, so likewise, day 12 scan or follicular tracking is very important. So this is one method, and this is the best for clinically practical way. There are other methods also. People can do urinary LH detection. They do a look at there are kits, commercially available kits. They insert it in the urine in the morning hours, and to see if there are double lines after 35 hours, it is they might ovulate. So it is in the urine. So sometimes some people do serum LH level also. So if the serum LH level peaks 10 to 12 hours later, they may ovulate, and you can advise them to have intercourse. Or if the husband's parameters are not normal, then we can think about an IUI around that time. And there is a test called serum progesterone levels. That is actually, if the woman complains of irregular periods, you may want to do it to see whether she has ovulated in the past. If this woman is ovulatory, this woman is not ovulating. So that is the concept. So you can't prospectively use this method, because when you have this, when you see that woman has already ovulated, it would be like this day 21, no, so she is not fertile. So it is only, you can retrospectively say that this woman has ovulated or not. Okay, so this is very important. So these tests, what are the tests available to predict or to say that woman is ovulating? So there are basic tests. So there one test is called cervical mucus pattern. People, in the past, we have used. We have asked the woman to check whether follow the cervical mucus pattern that become thick, scanty, and viscous by inspection. And some women do get mid-cycle pain, and basal body temperature goes up. So if you maintain a chart, basal body temperature will peak after the ovulation. So day 14, there will be a reduction, and all of a sudden there is a peak. So basal body temperature, mucus pattern, mid-cycle pain, transvaginal scan, LH kits, and progesterone levels. These are the methods to predict the ovulation. Okay, so what are the disorders? Why women don't ovulate? So as I said, 95% of the women, when they have regular cycles, they are ovulating. But having said that, some women don't ovulate. We group into three categories. One is group 1 disorder, secondly group 2, and group 3. Group 1 is a very unique condition. Hypothalamic failure. We looked at it. This is the hypothalamo-pituitary axis. If there is a failure at the highest level, that won't release GnRH hormones, and there will not be a LH level rise, and ovaries will not function, and there won't be estrogen. All hormones will be low. So this condition is commonly responsible for 10% of the cases. And Kallman's and Sheehan's, these are the examples. Kallman's disease and Sheehan's. So group 1 disorder, hypothalamic failure. Group 2 is the commonest one, WHO category. This is actually group 1, WHO group 1, WHO group 2, WHO group 3. Group 2 is disorders that arises due to dysfunction of the HPO axis. 85% of the cases are because of this. And polycystic ovarian syndrome is the problem, is one of the leading cause. Okay, and other conditions like hypothyroidism, Cushing's disease, all belong to group 2, and polycystic ovarian syndrome is and hypoprolactinemia, all this will belong to that. Okay. Group 3, ovarian insufficiency. Ovary itself, due to some other reasons, ovary loses its functional capacity. So that is called, in Turner syndrome and premature ovarian failure, they don't produce eggs, and the eggs level, quality, number of eggs will be very low due to atresia, atretic behavior, or some kind of failure. Okay, it can be iatrogenic, it can be genetic, or sometimes acquired causes like chemotherapy. So ovulation disorders, there are 3 types: group 1, group 2, group 3. So based on this, normally what happens is we try to induce, when we want to induce ovulation, we look at the pathology. If it is group 1, what will be the problem? Tell me, how do we induce ovulation? Can somebody tell? Dilshani, KAGG. If it is a type 1, this one, how do you induce ovulation? Tell me just a basic.
As it is a hypothalamic failure, we can give GnRH.
Yes, very good. GnRH, pulsatile GnRH analogs we give. So sometimes when the uterus is small in size, we give additional estrogen to increase the size of the uterus. And pulsatile GnRH analogs, there are regimens which you don't necessarily have to know. You could do that. So polycystic ovaries, we do very frequently. Group 3, Turner's, again, we use various techniques.
Recording stopped.
Not in the, not in the Turner's, but Turner mosaic, and premature ovarian failure. There are methods to induce ovulation. But commonly, we normally focus on, and in the undergraduate level, group 2 disorders. And when there is when there are women with polycystic ovarian syndrome, we induce ovulation. First line is weight reduction. Then we use drug called clomiphene citrate. Thirdly, letrozole, that is an aromatase inhibitor. Then FSH, FSH, LH in combination. And finally, there is a method called ovarian drilling. Okay, these are the methods. Clomipene citrate, you should know the drugs, usual doses, and mechanism of actions. Okay, what we do is when there is, we normally advise them to reduce the body weight and lifestyle modification. Once the weight is okay, we should induce ovulation by clomipene citrate. And also, third line, I forgot to mention here. Metformin is also an ovulation induction agent. Okay, this was a question. A lot of people had answered. This was a question. Okay, in 2 years ago or within last once, I think within last year, there was a question on ovulation induction agents. It is a non-steroidal compound. It has estrogenic as well as anti-estrogenic properties. Anti-estrogenic properties will act on the endometrium and thin the endometrium. That is a side effect actually. Actually you don't know, but it blocks the estrogen receptors so that there will be loss of negative feedback. Then hypothalamic GnRH will increase. It will impact or influence on the ovary to produce FSH and LH. Oh, it will act on the pituitary to produce more FSH and LH. FSH will act on the ovaries, and there will be one or multiple follicles that will be recruited. Usual doses, we give clomipene citrate 50 to 150, either daily or BD dose, and maximum 200. You should not give beyond 200. When you increase the dose, there will be thinning of the endometrium, and there will be multifollicular development, and there are possibilities of quadruplets, quintuplets, and all. We normally give one cycle, means when they conceive, when they have a period, second day to sixth day, 5 days, and we check the ovulation around 10th, 11th, or 12th day by transvaginal scan and tell them they have developed an egg or not. This is called follicular tracking. Up to likewise, recommended cycle number is 6 cycles. After 3 cycles, you have to check whether you need to go for the other level, like tubal test, sometimes IUI. Those are first 3 cycles will be successful in good candidates. Beyond 12 cycles, if clomipene citrate is associated with increased risk of ovarian tumors. Okay, side effect is hot flashes, breast discomfort, abdominal discomfort, vomiting, loss of hair, disturbed vision, and multiple pregnancy, and of course OHSS. So you should advise to stop the tablet if there are any severe side effects of these, or visual disturbances like yellow vision or blindness, all those things you have to immediately stop. So ovulation, this has a risk of a condition called ovulation hyperstimulation syndrome also. Then comes tamoxifen. It is given for breast cancer. It is implicated in endometrial cancer also. If you give it, for a long time, they will develop endometrial cancer. But it can be used in safely to induce ovulation. But this is not very popular. Bit old-fashioned. It also acts by blocking estrogen receptors and increasing GnRH secretion. But the good thing is no OHSS and no multiple pregnancies. Metformin, insulin sensitizing agents. It will increase the insulin's responsiveness to target tissues and reduce the hyperinsulinemia. And this will increase the, augment the metabolic effects. And mostly, this is used as a second or third line in PCOS women. And side effect profile, and this is the maximum dose. Side effect profile, you should know gastritis and vomiting, nausea, abdominal pain, lethargy, all these are side effects. Letrozole, and it is an aromatase inhibitor. It has no anti-estrogen effect. It won't thin the endometrium. So it is well tolerated, and nowadays it is very popular, and people even use as a first line agent. And combination of these agents, metformin, letrozole, also is a possibility. Gonadotrophins, FSH or LH, or either in combination. It can be recombinant one, it can be human urinary one, menopausal, they collect the way, based on the method that it is produced, the quality vary. Okay, nowadays we have highly purified recombinant ones. Those are genetically modified ones, and those act very simply and less side effect. Okay, so initially it was produced through the horse urine from the horses, urine from the pregnant horses, and then pituitary extracts were taken, and now menopausal women's urine were taken. So likewise, lots of, just read the history, it is interesting. So FSH or FSH LH in combination will also be helpful. And you don't necessarily need to know the dosage. Some lots of this is used in IVF procedures. When IVF, when you want to do IVF, your target is to produce multiple follicles. So you give from day one of the period, you give high doses of gonadotrophins basically, and around 11th 12th day you give another anti GnRH hormone to stop the ovulatory surge or ovulation. So you keep them in one plateau, whatever the phase without ovulation. Take her to the theater, pass a needle and take all the eggs. So that is called ovum pickup. And then you keep it in a freezer. You either put the sperm and make a the embryo and freeze it and keep. And when the endometrium is prepared and ready, when there is an endometrium in a good quality, you send the embryo to the womb. That is called embryo to the endometrium. Embryo to the endometrium. That is called uh, uh, embryo transfer procedure. You egg pick up, and you then do fertilization or whatever hatching, and then do the embryo transfer procedure. So this is GnRH. There are lots of regimes at agonist protocol, antagonist protocol. Sometimes when you do just for ovulation induction for PCOS, you give step up technique, step down therapy. So you just follow the protocol. There are regimes. You don't necessarily have to bypass those, by heart those things. And when you follow the eggs, when you do FSH and LH, you have to do frequent ovulation monitoring, because you can't wait till the day 12, because they might either ovulate or they will develop lots of follicles before the correct date. So you have to be very careful when you do FSH injections. When you give FSH injections, you may need to do scans from day 7 onwards, depending on the size. You have to do frequent ovulation tracking. This is the summary. Then finally, all this, when you do clomiphene citrate, 3 or 6 cycles, you have increased the dose, but they haven't produced the eggs. Then you label them as a clomiphene citrate resistant OHSA, ovulation, polycystic ovarian syndrome. In that case, you can go for the other agents, like you decide based on the experience. You give letrozole, or sometimes you go for FSH regimen. So even if this is failing, then very last resort is ovarian drilling. This is an invasive procedure. This improves the outcome because it affects it. We diatomize the stroma, which produces androgen hormones. So it works very well. Within 6 to 8 months, there is a good chance of conception. But this is not a favored option because it can damage the ovarian reserve. So next time, if it fails, IVF egg retrieval will be very difficult. So there are pros and cons, various methods. There are pros and cons. So what you do is, normally when you advise them for clomiphene citrate, you tell them this is the side effect, this is the dose, this is given to increase the size of the egg, and when to take it, what are the side effects, what are the when they should stop, and they should come on day 10, 11, 12 for a scan based on the size. If the egg size is 18 millimeter, if the endometrium is more than 8 millimeter, then you give us drug called a trigger shot. That is ppm, 5,000 units. After that injection, 36 hours later, they will release an egg. So when they have sexual intercourse around 36 hours from the time of injection, there is a good chance that they will produce, they will conceive. Ovulation induction, follicular tracking, trigger injection, and time sex. If the time sex, if the husband's partner's components are not good, then you do an IUI around that time. This is the simple summary of ovulation induction. I think half of you are sleepy also. Yeah, any questions? Okay then. Okay, thank you then. I will stop the lecture.
Excuse me, sir.
Yeah.
Sir, how do we calculate a cycle?
Cycle in the sense, it is one cycle means if you give one full clomid dose and you do a scan around 10 days, then whether they develop a follicle or not, it is considered as one cycle.
Okay, sir. Thank you, sir.
Okay. Sometimes you have to check, you maintain a chart. We normally check the previous dosage, previous size of the egg, and whether they have had a mature follicle or not. And secondly, you have to adjust the dose. Okay. Okay, then, in the absence of questions, I will conclude.